Lovely. And I'm just going to now hand you over to Dr. Alderman. Host.
Well, thank you very, very much indeed, Michelle, for the kind introduction. It's very kind, and I don't know that I'm as talented as what you've portrayed me, but I appreciate the kindness nevertheless. So look, I'm going to just share my screen now and just make sure that actually works. Can you all see that screen? We're okay? I'll assume silence means assent. So here we are. This is the talk today that I'm going to be giving. So look, to begin with, the more astute amongst you will have noticed that that's not me on the opening style. I mean, close. I've got dark hair, going over to a bit grey now, but the part below is me. That's me. And my area of expertise primarily is clinical pharmacology, although we'll talk more about that as we go along. I do have psychology qualification as well. And so it's quite useful at times to be able to walk the line and understand both perspectives of treatment. So without focusing too much more on me, we'll launch into the talk. So hopefully this will work. Looks like I've fallen at the first hurdle. Let's see if I can get, no, here we go. All right, so we're going to be talking about medications, and I don't need to tell you, I do believe that medications are widespread in all parts of society. If the group that's watching this talk today is indicative of the Australian public, many of you, if not most of you, will be taking some form of medication. Some of you will be taking more than one medication. And we encounter this thing called polypharmacy that I'm going to talk a little bit about. But polypharmacy, for those of you, and you probably heard the term polypharmacy, for those of you who are interested in the semantics, we define by a person taking 5 or more regular medications. And you might ask why we use the term 5, why we settle on 5. And sorry, I've just lost my slides there. I'll see if I can find them again. Something changed then. I don't know why. Can you all still see the slides? Maybe. Let's hope.
No,
Yes?
I can't see anything.
You can't see them. Can't
No.
see the slides. All right. Let me go
Sorry
back
about that. I don't know what happened there.
I'll see if I can get them back. Just bear with me for a moment. Share screen.
There we go. Okay.
That's better, thanks.
All right. Look, I might leave it like in that view unless anybody's got any objections, because I don't know how successful. Well, maybe. Look, I'll try again. I'll try again with the whole screen. But okay, we'll come back and continue. So what I was saying was polypharmacy is generally, we draw the threshold for polypharmacy at 5 or more medications, and this is because when a person takes more than 4 medications per day, the likelihood of one of those medications causing them a problem increases exponentially. So it's not a linear relationship. It actually goes up like a J curve, and that's why we choose 5 or more as the threshold for polypharmacy. It's not to say that a person taking 2 medicines can't experience harm from them. It's not to say that a person taking 10 medications will always experience harm from them. It's a rule of thumb. Drug-related harm is very common, and it might shock you. I won't bore you with the statistics, but literally millions of episodes of medical care and hundreds of thousands of hospitalizations take place in Australia every year directly as a result of the effects of medications prescribed for people. So I'll let that sink in for a moment. These are the things we're trying to give people to do good, not harm. And nevertheless, they are causing serious medication-related harm. We'll come to talk a little bit more about that as we go along. And it's fair to say that all of these things, medication use, polypharmacy, drug-related harm, are especially common amongst people with workplace injuries. And that's where I spend a lot of my time consulting in this space, trying to get to the bottom of potential medication-related harm. So Some of the things I'm going to be talking about, we're going to talk about which medications are commonly used by people with workplace injuries. We're going to talk about the types of issues that are encountered and the nature of what we call medication-related problems. I've used the abbreviation MRP there, but medication-related problems are more than just side effects of drugs. There are quite a few other things that we do encounter. And finally, we'll talk a little bit about the services that I can provide through the auspices of our colleagues at MAG.
Please excuse me for interrupting, Doctor. There's a number of people who have not muted their microphone. Mr. Bashara and Ms. Tiziani, would you please mute your microphones? Also, Mr. Lehman. This is so that noise in your home or workplace doesn't interrupt the recording. Thank you.
Okay, so we'll move on. So look, I just thought I'd give you a little bit of a walkthrough of some of the more common medications that I see in requests for Medicolegal reports. And here are some of the critical examples, and I'm sure none of this will come as a surprise to anybody who works with people who have been injured at work. So the issues that I encounter are often related to opioid medications. Sometimes I'm asked what's the difference between an opioid and an opiate. In practice, the answer is very little important difference. Opioids are things that occur in nature. They are derived from natural sources, things like morphine and codeine, for example, which are derived from poppy plants, whereas synthetic drugs like oxycodone, tramadol, tapentadol, buprenorphine, fentanyl, they are all things that are made in a lab, and strictly speaking, they're called opiates. In effect, they produce the same effects. The next class of drugs are the gabapentinoids. The most frequently encountered one these days is pregabalin. We also see gabapentin and topiramate. And you, look, I just remind you, I'm using the generic names here. So oxycodone is endone, tramadol is tramal, codeine with paracetamol is Panadine Forte, tapentadol, the name will come to me in a moment. Temgesic is buprenorphine, pregabalin is Lyrica, gabapentin is Neurontin, and so forth. So the non-steroidal anti-inflammatory medicines, NSAIDs, drugs like ibuprofen, which you can buy, surprisingly enough, without a prescription, diclofenac, which is Voltaren, meloxicam, celecoxib, which is very widely prescribed in this population as well. So they're used as painkillers and also anti-inflammatory agents. You've got psychotropic drugs, many of which are antidepressants like Cipramil or citalopram, sertraline, which is Zoloft, mirtazapine, which is Avanza, duloxetine, venlafaxine. Diazepam is not an antidepressant, but it's this is Valium and its cousins. And sometimes people use drugs with different generic brand names, pardon me. So this is why I've tended to use the generic name for them. I've also mentioned their gastrointestinal agents like esomeprazole, which is Nexium, pantoprazole, which is Somac, as well as antacids and laxatives. And then also to remind you not to forget about the effects of things that are purchased, not necessarily from a pharmacy, not necessarily from prescribed by a doctor, but things like supplements and complementary and alternative medicines. In particular, things like fish oil, glucosamine, turmeric supplements, garlic, ginger, which are terrific in a curry, but not necessarily so good for you for some illnesses. But anyway, all I mean to say is that there are lots and lots of things that we encounter, and I see all of these things virtually every time I do a medico-legal assessment, as well as other things, of course, too. So the things that I do in a report, the first thing I do is to assemble a full medical and medication history. So establish all of the relevant medical history and all of the medications that a person takes. And when I talk about a medication history, I'm interested to know what they're taking, how long they've been taking it for, at what dose, and whether the dose has been stable or whether it's been altered recently. And this is one of the reasons that it's very important, if I can, to do an interview with the person I'm assessing. It's not obligatory, it's not mandatory. I can do file reviews, but the quality and reliability of the information that I can get from an interview is much richer than what I can from a file review. People often reveal things they weren't intending to reveal in the context of an interview as well. And so we can often find out things that are relevant that otherwise wouldn't have come to light. I'm often asked to indicate which medications are used in relation to compensable issues and which of the medications the person is taking are for non-compensable or incidental issues. And I should point out, I often get told, oh, look, this is something they're taking that's not related to the compensation, so you don't need to know about it. Completely untrue. Very often I find people who are claiming, for example, of something that's caused by a medication that's completely unrelated to their compensable issues. So it's critical I know all of the medications they're taking. I will assess the timing of any adverse events relative to a particular event. So I'm looking to establish whether there was pre-existing use of a medication or pre-existing issues. So one of the things, for example, I often get asked about are dental injuries, dental decay, grinding of teeth, bruxism, tooth loss, those sorts of things. And if, of course, a person has a long and rich dental history that precedes their use of any medications for any compensable condition, it's hard to run a cogent argument to say that their dental issues relate to the medicines they started this year because of their compensable issue. I'm sometimes asked to give an opinion as to which medications appear justifiable or reasonable in the context of compensable issue. Obviously ask whether a medication could be causing adverse effects or side effects, and whether there are interactions between the medications the person is taking. I'm often asked and can provide information about what constitutes a reasonable investigation, assessment and management of issues. So whether I'd recommend any, that a person should have an endoscopy or some blood tests or some imaging and so forth. I do also do toxicology reports. So just recently, for example, I did one for a person who worked for a local council who was spraying glyphosate, which apparently got into the cab of his car and made him feel quite unwell. And then he launched into a 10-year quest to be compensated for all kinds of things for his glyphosate exposure. And we went through what the blood and urine tests mean and how that relates to the likelihood of him experiencing problems. Increasingly now, I'm asked about the use of medicinal cannabinoids, and without launching into an hour-long talk about what medicinal cannabinoids are, suffice to say it embraces the use of products that are derived or synthesized from cannabis, increasingly prescribed in Australia or around the world, not anywhere near as benign as what people might portray them as being. And I'm sometimes asked to provide an opinion as to whether it's reasonable for an insurer to fund access to medicinal cannabinoid products, which are quite expensive in Australia at the present moment. Sometimes I'm asked whether or not being treated with a medicinal cannabinoid or indeed other medicines will have effects on a person's capacity to return to work. So, for example, if a person is working as a fly-in, fly-out employee in a mine, they will often have obligatory drug testing policies, and the drug testing will reveal the presence of cannabinoids, which renders them in breach of their contract with their employer and unemployable at that site. People in the military, for example, there's a whole different set of law which applies to people in the military. And again, this is a complex area for them. So just without going, and we could have another talk another day all about medicinal cannabinoids. It's a fascinating area and quite interesting in itself. And then the other thing I get asked about is preventative interventions. What could be done to prevent this person from coming to harm in the future because of the medicines they're taking right now for their compensable issues? And finally, I'm usually asked if I can provide other information or observations that I consider to be relevant to the case, which I often do, and can be quite helpful for people considering how to manage a person's compensable issue. So you can see there's quite a broad range of things that we can touch on in the reports, and in many cases I touch on all of these things. So I just wanted to run you through some of the issues that I am asked about in connection to medications taken by people. The first one is effects on the central nervous system. So whether a person can experience cognitive impairment or dulling, confusion, sedation, and then serious psychiatric syndromes like depression and psychosis as a result of their treatment with medicines which may or may not be related to their mental state. So sometimes, for example, treatment with high-dose opioids and in combination with pregabalin or Lyrica can cause cognitive dulling, and I might well do some desktop assessment of their cognition using a standard instrument, and then I might well recommend that a person should be referred for more specialised neuropsychiatric assessment if I believe that to be relevant. So that's one area in which we see quite a lot of questions arising in connection to reports, and this is a very common thing with the medicines we use for people with compensable injuries in the workplace. So opioids and psychotropic drugs and other drugs all have the potential to impact in this area. The next area I wanted to highlight is the oropharynx. Xerostomia is the technical term that's used to describe dry mouth. It's more than just an inconvenience. Your saliva in your mouth is protective against tooth decay. Prolonged suppression of the production of saliva can lead to tooth decay, serious tooth decay that can lead to loss of teeth, in some cases quite serious pathology in the mouth that might end up costing thousands of dollars to remedy with implants and the like. Bruxism or grinding of the teeth is another one that I'm often asked to comment on, and it is quite common with some of these medicines. Temporomandibular joint dysfunction, so your TMJ joint is here, and basically it can become sore or dysfunctional as a result of things that happen in the mouth. Dental caries, which is tooth decay, basically, I'm also asked to comment on. So these are all things that I'm very commonly asked about, and whether or not when I see a person that their dental decay or their dry mouth or their grinding of their teeth relates to their medicines. This is where taking a careful history is important. I've seen on a number of occasions people claiming to have bruxism and dental decay as a result of the medicines taken for their compensable injury, and when I question them more carefully, it turns out that they've been using methamphetamine in the past, which causes all of these things and basically renders any consideration of drug-induced problems from the compensable medicines very fraught indeed. And I point that out in the report, of course. Sometimes I'm asked about whether treatment with a particular medicine might have led to heart disease, high blood pressure, a stroke, or a blood clot, and there are medicines that can cause these things. And they can be quite catastrophic, so that's another one to take on board. This is another one that's very common, gastrointestinal issues. So I'm often asked about whether a medication might be contributing to reflux or issues in the gullet, the esophagus. Dyspepsia, which is a broad and relatively non-specific term that could be best described as upper gastrointestinal discomfort. Nausea and vomiting, diarrhea, and constipation. Constipation is almost the rule rather than the exception when it comes to treatment with opioid medications. It is important to work out, however, that many times it can be managed using the right medications, and so it's not irreversible and it shouldn't be regarded as a source of permanent impairment. Endocrine conditions, things like can a medication cause or contribute to diabetes mellitus, osteoporosis or thinning of the bones, erectile dysfunction and sexual dysfunction in general, and weight gain, and these are all really common ones as well. We see these all the time, particularly the last two, erectile dysfunction and weight gain, are particularly common themes that I see in my reports as well. So putting all that together, it's not uncommon for me to be asked about the potential contributions of a person's present and past medications to 2 or 3 or 4 of these areas. Quite common, actually, for me to see all of that in a report request. I will say that when I get a request, the more explicit and specific the questions are, the better, to be honest. Broad, general, non-specific questions tend to generate broad, general, non-specific answers, which is not really what you want or need. So I really just wanted to point that out to you. So what happens during an assessment when I do an assessment? Well, I might do a file review if that's the case, or I might do an in-person interview, and it can be either live or virtual using a platform like Zoom. So I want to, and then I might also be asked to do a supplementary report because I might identify issues that are unclear, or the history is incomplete, or I can't really make a judgment without further information. So that's what I do. Now, a file review can be done, but I will point out that a file review is utterly dependent on the comprehensiveness of the information that is supplied. So if the medication list is incomplete, if the medical history is incomplete, then I can't ask somebody about that. So I'll often point out as a limitation in a file review that I haven't had the opportunity to talk to a person about all of the medications they use now and have used in the past, medications they take without a prescription, medications that they haven't told their doctor about, which is quite common, and so on. So a file review does have its limitations. It's not useless, and it can form a basis to begin a discovery process. But in general, an interview I find preferable. So, and at the moment, I would say I do about 50-50. About half of my reports are based on file reviews and about half on in-person interviews. So the quality and completeness of the review will depend critically on the information available. So this is not to say, and some people adopt a very over-inclusive result, and it's not uncommon for me to get a 1,000-page file to be sent to me, which includes all kinds of things that I don't need to know about. But what you need to understand is if you send me 1,000 pages, I need to read 1,000 pages. So the cost of the report goes up because I can't assume that things in there are not relevant. They're sometimes very relevant, and I need to make certain that I cover off on them. So on the other hand, sometimes I get sent things that are manifestly inadequate. And I was only saying to Michelle before that I got sent one only this week where the most recent information about a person's medication was from 2018. And that was when the claim had arisen. And of course, anything and everything could have happened in the period after that. So I just wanted to point out that the more information I can get, the better and more helpful the review will become. So the in-person interview is superior for gathering full details, especially with respect to comprehensive medication use before and after critical events. And also sometimes, and I'll give you an example. So I will talk to a person and they might be telling me that they want to claim for a dry mouth, and at the same time, they might be telling me that they want to claim for reflux. There's a symptom of reflux which is called water brash. Water brash is the sensation of your mouth suddenly filling up with saliva. So I'll say to a person who's just told me that their mouth is constantly 24/7 dry, I'll say, well, let's move on now and talk about your reflux, and we'll go through some of the common symptoms. And then I'll say, well, by the way, do you ever get this symptom where your mouth suddenly fills up with saliva? Oh, yes, happens to me every day. Which then is kind of implausible when they tell me that their mouth is constantly dry. Either you can or you cannot make saliva. So an interview can sometimes enable us to understand what's going on in a more detailed fashion. We also look for to establish the medication details before and after, because sometimes, you know, people might be running a case or running an assertion to say, well, this is a side effect that came about because of the medications I take for X or Y. It's pretty implausible if the person's been on that medication for 20 years before they had their accident at work. So trying to assemble a full medication details before and after is very important. Reports from hospitalizations and investigations are very helpful. You might say, well, what does a pharmacist need to do with a for example, an X-ray, but sometimes they can be very elucidating. So I would say err on the side of providing me with more blood test results and more investigation results. I'll discard them if I can't use them. Now, I wanted just to point to you to a thing called the Naranjo causality algorithm. And this is a mathematical instrument that's used in my field to assess the likelihood of causality in relation to a specific event. So we use the Naranjo scale to generate a score between 0 and 7. And a score of 0 says that this is very unlikely to represent an adverse effect associated with this person's medication, whereas a score of 7 suggests that it's almost certainly going to be caused by the medication. In reality, we most commonly encounter scores in the range of 3 to 5, which is still useful information. But the other thing is, I can tell you that magistrates are very interested. If it ever gets to court, magistrates are very interested to know what, when I talk about the Naranjo score, this is a kind of objective instrument that they can see that I've used to assess the likelihood of causality. The other thing I'll put into a report is recommendations for future investigations, assessment and management. So for example, if I'm investigating gastrointestinal effects like reflux, I might say I recommend this person should have esophageal manometry or an endoscopy, or they should be tested for Helicobacter pylori, which are all things relevant to a diagnosis of gastroesophageal reflux disease. I might investigate response to treatment and then make suggestions about future management. So these are all things that come from my reports. So that's a little run through of the sorts of things that I get involved with. And look, just to finish up, I wanted just to point to you in the direction of this thing called Medal. I don't know whether any of you have ever come across it or not, but Medal is a game a lot like Wordle, the thing from the New York Times, but it's actually a medical word game for medical professionals, doctors, nurses, pharmacists, psychologists, and the like. And I'll declare a self-interest because my son created it and he has put it up on the internet with my help to raise money for COVID vaccination in developing countries. So if you like playing a word game and you want to support a good cause, have a look at that web address there, medalgame.com. None of the money goes to my son or me. It all goes to COVID vaccinations in developing countries, and it's a bit of fun. So on that note, I'll wind it up. I think we're about on time, Michelle. Is that correct?
Yeah,
and
that's
I'm
fantastic.
very happy to take any questions you might have.
Can I just say firstly, wow, I learned so much from that. That was awesome. Thank you too for presenting that in a way that is meaningful to people like me who are non-medical. It was absolutely fascinating and very, very informative and helpful. And the medal game thing, I definitely will be looking up in that, given that I spent 3 years living in Papua New Guinea, and I watch what's happening in that country every day with a broken heart. So that's amazing. Thank you so much for that contribution. People, anyone have some questions that they would like to ask? Please, now is your time to unmute and jump in. I said that this can happen sometimes, Chris. When the presentation is so comprehensive and good, people are blown away and they don't have any questions.
Actually, Michelle, Chris Lehman here. I just do have a question for the doctor, if I can.
Mm-hmm.
One of the difficulties we face as solicitors is often we're not medical professionals. We like to sometimes convince ourselves that we know more about the medicine than we really do. So when we're looking at a letter of instruction, it's often very difficult, I find, to sort of go, well, some things are very, like medical certificates often don't contain any information that you would find relevant, and they take up a lot of space, but it is sometimes very difficult to know what is relevant to the doctor and what isn't relevant. Well, how do I make that call? And of course, the the burden that we all have is that there are, as you've mentioned, thousands of pages of paperwork. So from the point of view of the medicinal side of things, would I be correct in saying potentially the more relevant information for you would just simply be the very beginning of the claim and the history maybe before it, and then the very current, rather than everything in between, like the work injury potentially and the date of your assessment? So let's say the injury was 5 years ago. Whether you see something in the second, third, fourth year won't be as relevant as what is happening now and what happened at the injury and what was the case before. Would that be a correct or dangerous assumption?
Not always. Sometimes you'd be right, sometimes perhaps not. And I'll explain why. So things evolve. So if a person, and I'll give you the example again, go back to the teeth, because that's one I see a lot. If a person's claiming for dental decay, one of the things that's important is that they need to have gone to the dentist every 6 months. And I know that that's not something anybody really enjoys that much. But the reality is it takes about 6 months for a dental carie to, from scratch, develop to a point where it's actually of clinical relevance. So if you're going to the dentist once every 6 months, it means that you're not going to have dental caries appear that are so severe as to require a tooth extraction or other sort of fairly catastrophic treatment. So watching the evolution of a syndrome can be important at times. Likewise, weight gain, for example. You know, we often see people who say, I put on 30 kilos while I'm taking this medication. Well, sometimes it's true and sometimes it's not, because sometimes you can see that in fact they put on 30 kilos, but most of it was, 6 months, well, in the 3 months after their injury. And then the majorities remain pretty stable. So if it was the medications, it wouldn't necessarily be the case. Sometimes it's just because they become inactive or they're comfort eating or things like that. So a longitudinal history can be important. And my advice would be to err on the side of over-inclusiveness rather than under-inclusiveness. What I tend not to get value from are very voluminous reports from, and this is no disrespect to anybody, but people like physiotherapists or occupational therapists who are assessing a person's environment, their potential work capabilities, their and these are all valuable things, but they don't tell me much about a person other than that they're impaired to a degree. Do you know what I mean?
Yep, definitely.
Yeah.
Definitely.
So those sorts of things, I get, reports with people, pictures of people's stairwells saying Mr. Smith has difficulty climbing stairs. I don't doubt that for a moment, but that's probably not relevant to what I'm doing. Whereas if I get a report that says Mr. Smith can't climb stairs because his pain in his knees is poorly controlled despite not being on all this medication, well, that tells me something as well. That's a different thing.
Yeah, good question, actually, Chris. And it's something that we get asked ourselves as providers all the time. And I think Chris's answer there, Dr. Alderman's answer is a pretty good one. And it's also about speaking about the type of specialist too, because, for example, hospital notes where a nurse goes in every hour to talk to the patient and say, have you done a poo? Would you like a Panadol? How are you feeling? May have some greater value to Dr. Alderman in an assessment than, for example, an orthopaedic surgeon following up on a knee replacement who really isn't interested in whether that person has gone to the toilet or needed a Panadol. So I guess it's also very much about the nature of the matter. But are there any other questions, people?
Just on that too, what I will say about hospitalizations is that discharge summaries are especially helpful. They often have results appended to them. And then major investigations, things like, what happened when a person had surgery? Did they have an endoscopy and what did they find? Did they have a colonoscopy? What did they find? Did they have a CT scan of their head and what did they find? it's difficult for me to make a case that someone's cognitive impairment is because of their medications if they've had a CT scan of their head and they've had a whacking big stroke, or they've got, incipient Alzheimer's disease and so forth.
Yeah, fair enough. All right, any other questions, people? No? Thank you once again so much, Dr. Alderman, for your time and that excellent presentation. Everybody, you'll receive an email with a link to the recording within the next couple of days. Thank you once again. Have a great rest of the day, everybody.
Thank you to everybody.
Thanks
for being so kind.
Bye.
All the best. Bye-bye.